If you're considering a free birth, we are pretty empathetic and understand a lot of the reasons why you would be doing that. And we talked about that in our previous video. This video, we're focusing on the dangers and risks of free birth. We're not trying to scare you. We're not really even trying to dissuade you. We just want to present you with all the information so that you're educated and you can make a good decision for yourself that keeps you and your baby safe and gives you the best birth experience that you can have. I'm Rachel Moises from the Mighty Mama Movement. I'm a mother of 8.
And I'm Heather, a midwife and family nurse practitioner.
Okay, we are going to be very real and raw and straightforward with you. We're not beating around the bush. We're not trying to be euphemistic. We are very pro natural birth, pro low interventions, pro hands off, and all of that. And we really understand the people in the free birth community, what they're looking for and what they want. We also understand the risks involved with free birth and the real life consequences that can happen in a small percentage of cases. And we know that you don't want to be one of those small percentage of cases where you potentially have your baby die or you die because of the risks that come with an unassisted birth. Okay, so let's talk about some of the really common things that can go wrong that can become life-threatening very fast. Shall we start there?
Yeah. So the first one is hemorrhaging. It usually happens within minutes. We have named it turning on a faucet because you can hear the blood flowing out of the woman. And it can be stopped with the right herbs, with the right medications, with the right tactics that it takes to know what is happening. But if you don't know those things, if you don't have those herbs, you don't have those medications, then 10 minutes can make the difference between everything is good and this was a disaster.
Okay. With my last birth, I hemorrhaged afterward.
Mm-hmm.
I don't know how serious it was compared to other hemorrhaging events, but it felt pretty serious to me because there was a point where we thought we had it under control. And if you don't know, Heather's my midwife, and she told me, okay, I think we're under control. We're going to have you just sit there and nurse your baby for a few minutes. Let's see how it goes. And a few seconds later, I told my husband, I don't know if I just wet myself or if that was blood. And it was enough blood that it was just like,
right.
And I'm sharing this story not to scare you, but to let you know, I wouldn't have realized that this was a problem. This was already that they've been working on it and been doing all the things that they need to do to get it under control. And then obviously they had to come back and do more. But when you just barely give birth, you can almost not tell even that you're bleeding anyway, and you've got you're wet and everything.
Fluid
you
and
really
everything,
can't tell, honestly, especially, if you're already, like if you did water birth, I guess you kind of see it coming. But the point that I'm making is, if you're all on your own and it can become dangerous so fast, it's hard to even realize this has become dangerous.
It really is, because you think, okay, blood is normal. We're going to have, certain things happen. Babies don't breathe right away. They take a little bit of time to transition. The one thing that happens in emergencies is a time warp. So we have the program that we use has little stop clocks on it. And we do that because when you have some of the complications that can happen, a resuscitation, a shoulder dystocia, a hemorrhage, what seems like 10 minutes has been 45 seconds. And on the flip side, what seems like a minute has been 6 minutes. Mm-hmm. And so I rely on that a lot because I know I'm in this time warp and I need someone calling out times for me in emergencies so that I can say, I have time. Let's keep doing what we're doing and until it works. Or too much time has gone by, we need to change gears. Mm-hmm. And that's me, who's handled hundreds of hemorrhages and shoulder dystocias and resuscitations. But imagine if it's someone that this is their very first time, the time warp that they would be in.
Okay, Mom, a quick mom-to-mom moment. I have to tell you this because I wish someone had told me. As you may know, I'm a mama of 8, and my first 3 births were rough. I just thought birth was supposed to be that painful. Nobody ever pulled me aside and said, hey, there's actually a better way. Then with my 4th baby, Heather, the midwife and nurse practitioner here, taught me something completely different, a method I had never seen in any book or video or internet research. And I ended up dilating to 10 centimeters with zero pain. After 8 babies, I can honestly tell you this method works. Most mamas just never learned these strategies. Even if they want to avoid an epidural, they feel like they will cave once things get intense. That was totally me. I had done so much research, but I never found a real method that made birth actually manageable. And that's why Heather and I started teaching this, because birth does not have to feel like torture. So here's your little insider tip. We put together a totally free class for you. It teaches the most effective technique to reduce contraction pain and gives you a sneak peek of our full 10-step practically pain-free birth method. If there's even a tiny part of you that hopes birth could be easier, click the link below and grab your spot. Seriously, you will be so glad you did. And you never handled those things on your own,
right,
your first time, or I guess even now you don't handle those 100% on your own, right? You've
right,
got a team there that's
exactly,
helping you with the emergencies that come up.
exactly.
So if you're doing a free birth, you don't have anyone with you who has that experience.
Right.
You don't have a team, you don't have your own personal experience, and you also have your potentially optimistic viewpoint
Right.
that this isn't that bad, this isn't that big of a problem, and you don't realize it's a problem until you've already wasted really precious time that you could have spent addressing the problem and getting it under control, right?
So, you know, people say this, oh, you know, at the hospital, oh, we've seen home birth transfers and they've gone bad. And we say, you don't see all of the home births that have gone so well, or all of the birth center births that have gone so well. And I mean, bad things happen in the hospital too, you know, so choosing wisely, and we have videos on, you know, how to choose wisely and what to do. But I have had a fair amount of women that have gone unassisted. They've had free birth and they have called me. I've had a grandma, I say grandma because it was the mother of the woman giving birth, right? So the baby's grandma. And she called and she said, the baby's just been born. They're singing happy birthday to the baby. And this baby is dying in front of my eyes. What do I do? And so I was able to say, okay, well, do you have this? Do you have this? I need you to do this and this and this and this. And that grandma intervened and was able to, you know, she told the parents, you get in the car now and we go, because baby was breathing but barely. Or I'm taking the baby next door to the fire station was right next door to their house. And that baby was extremely critical. And luckily that baby lived by, we don't know how, like it was really by the grace, you know. And or other ones where they say, hey Heather, I had my last baby with you, and I'm like, yeah, how are you doing? They're like, oh well, we just gave birth and there's a little bit too much blood. And I'm like, well, congratulations, you know, you had another baby. And they just figured, I said, you know, why did you choose this? And they said, well, our last birth or our last two births went so well that we figured we'd save money on a midwife. You know, we just do it ourselves. It just seems so easy. Yeah. And I end up, you know, running out to their homes. A lot of midwives will not do this. They're just like, I'm sorry, call an ambulance, go to the hospital. Yeah. I won't take the responsibility. But I've gone out to their house and I've, you know, stopped the hemorrhage and had to do IV fluids. And luckily, the hemorrhages were not severe hemorrhages, but they could have turned into it if they hadn't said, hey, there is more blood here than we're happy with. Or I've gotten phone calls from people, once again, they've had two great births. They figure, hey, I'm going to do this unassisted. And they call and they say, and bleeding is the big one. You know, this is what's happening and this is what's going on. And I'm having to instruct her sister, because they would refuse to call an ambulance, which is their right to refuse it. And so I'm like, all right, this is what you need to do to stop this hemorrhage. Did you get these herbs? Did you do this? And if you didn't, then, you know, we're going to have to do bimanual compression and you're going to learn over FaceTime how to do this. And they do it. And luckily for me, I haven't had anyone that has had a death, but we've had some really close calls on the phone. And I'm like, guys, it's, you know, it's not that big of a deal. I'll sit in the corner. I'll be very non-invasive. You know, typically you can find somebody. But if you're going to do this, you've got to get the training you need. You need to take an NRP class, neonatal resuscitation, not CPR. CPR is good. Okay, so take CPR.
Right.
But neonatal resuscitation is different from CPR. They are not the same at all. And so you really need to find and take that. There's one, if you don't want to take the medicalized, there's one called Helping Baby Breathe or Helping Babies Breathe. That is meant for home birth situations, out of hospital situations. It's very, very good. It's taught a lot in Africa and other countries. There are videos that you can find to help with this. Does it take the place of a trained professional? No. But
and I want to talk about that. Okay, so I totally agree with what you're saying, that if you're going to do this, you get all the training you can and prepare. But I also want a little reality check. Okay, so I'll say my experience here. I got my EMT certification when I was younger, and as part of that, they show you a whole bunch of really gory, gross stuff to make sure that you can handle seeing all of that and get you a little bit desensitized. And so, and also you have to do a lot of practice in being calm in an emergency and handling emergencies like that, right? So I thought that I'm really good at that. I can handle blood and gore. I can stay calm in an emergency. I've had training. I'm certified, etc. One time my toddler fell and busted his eyebrow open, and it was quite big, and there was all the flesh. I mean, it was a little gory. I could not do anything calmly. All I wanted to do was pick him up and hand him to someone else and say, take care of my baby. Like I couldn't handle it. Was just it just needed stitches. That's all he needed. But in the moment, I couldn't handle that. And so you're taking a lot of risk on yourself and responsibility that after you just gave birth, or maybe you think, oh, it's okay, my partner, my husband, my mom, whoever, and they've just helped you through this birth, who knows how long it went, and all of that, that whoever you're counting on, whether it's yourself or someone who's helping you, is going to be able to stay calm when it's their own baby, their own grandchild, or it just becomes real. And you don't, I think you're expecting a lot of yourself and your team to think that, oh, it's okay, we've got it. Like I watched some videos, I can handle this, you know?
And that's a really good point, because one of the births recently that was an unassisted, her husband was an EMT, or he might have been a paramedic, actually. I believe he was a paramedic. And it was the sister that called me and said, what do we do in this case? It wasn't the husband that was a paramedic. It was the sister that I gave the instructions to and what to do, because it was his wife that was having the issues.
It's a different situation.
Exactly. So when my son's wife my daughter-in-law had our grandbaby, I was the midwife for her birth. And I still had the doctor I work with. It was at the birth center, but I said, I need you there. Just stand in the corner and be there until the risks are gone. Not that I can't handle them, but this is my grandchild. I cannot be the fallback person in case something serious happens, because when you have that emotional attachment, it warps how you react, how you respond, because emotions are so strong.
And you can't know how you're going to handle that until it actually happens. So
exactly.
I think if Heather, who has, I mean, that was not that long ago, right?
No.
And she has all of her experience and certification, multiple licenses and all of this, and she still realized, I don't know if I'll be able to handle it if something goes wrong and I have to, deal with the emergency. So I don't know. I certainly wouldn't have a lot of confidence in myself in a situation like that. Okay, let's talk about shoulder dystocia. That's another common thing that you may be faced with if you're anyone who's giving birth.
And so to prepare, there are, some videos. Gail Tolley, I believe, of Spinning Babies, has a really good video on it. She talks very, very, very slow in it. But beyond that, it's a very good video. The information is good. You just have to be patient. But you know what? It is hard. You have to have many shoulder dystocias as a midwife, handling them before you feel confident and not afraid of a shoulder dystocia. The number one thing I have seen in the hospital that scares the bejeebers out of the doctors is shoulder dystocia.
Can we
And
explain real quick what it is? We didn't
yes,
mention.
a shoulder dystocia is when the head comes out, but the shoulders are caught on the mom's pubic bone or somehow caught on in the pelvis. And so the baby's head comes out right to here, and then there's no movement. And the risk with that is you have a maximum of 7 minutes to get that baby out. And in most cases, you have 3 minutes to get baby out. They just say 7 is the extreme end. And after that point, you're doing a full resuscitation and just crossing your fingers that everything turns out well, because baby has had oxygen deprivation for 7 minutes. So like I said, most 3 minutes is your max. 7 minutes is what they say. Just there's no coming back from 7 minutes.
Okay, I don't know if I want to say this or not, but I read an article recently about a baby that was decapitated during the shoulder
Yes.
dystocia. That was horrifying. I'm sorry, maybe I shouldn't even tell that to scare you, but
Right.
it actually can happen, and it is a known risk of
Right.
shoulder dystocia. Even this was in the hospital.
Yeah.
With a doctor.
Exactly. And there are a lot of different things. Providers will put their fingers under the armpit right here, and that can damage that nerve. So that brachial nerve, and then the baby can't use that side of the body, or they have to go through physical therapy. And so there are specific ways that you need to handle a shoulder dystocia so that you don't, and by decapitate, it doesn't mean the head came off. It means that the spine was separated. And so the skin was still there, but and that you're not going to survive that.
Right.
So that is one of the risks. You have the brachial plexus injury that can happen. Some of the minor injuries, and they sound like a big deal, but they're not, and I'll explain, is a broken collarbone or a broken humerus here. And they'll sound like, oh my gosh, that's huge. But here's the thing, collarbones heal easy peasy in 2 weeks.
On a newborn.
Okay. On the arm, they heal within 2 months. And here's the interesting thing. You don't even see it on an x-ray later in life, because their bones are not completely formed. So they heal very, very easily. Now you may think, oh my gosh, Heather, it's broken arm or broken collarbone.
Nobody wants that.
Right. But here's the thing.
It's compared to
bones heal, brains don't.
Yeah.
A brain does not heal. Bones are easy. I remember I had a mom with a severe shoulder dystocia. It was one of the worst. It was close to 7 minutes. It was very close. And it was the worst collarbone break I'd ever had. And so, because normally they're just this little like click, 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 but this was a pretty big one. So I called the pediatrician because we were in the middle of nowhere on a Saturday night. Nothing's open. Like, oh my goodness, right? It would have been, an hour to the hospital kind of thing. So I called my pediatrician. I said, hey, do I need to be worried? And he said, I can't see this break, obviously. He said, but I can tell you this. I've seen over 500 collarbones broken from shoulder dystocia. It happens all the time. And every single one of them has healed without a problem. Wow. I've never had a complication from it. And so I said, thank you very much. And that one healed fine. And so once again, you think, oh my gosh, that's not great, but it's so much better than a brain injury.
Yeah. So I've had 8 babies, and 2 of mine have had shoulder dystocia. And so
no broken collarbones.
Yeah, no broken collarbones. I just want to share that with you. Like, these are my last 2 babies. So I had already had 6 babies, no problem, no shoulder dystocia, no issues at all.
And your babies weren't huge.
Yeah. And it just happened. And so it's kind of like playing Russian roulette. Like the percentage of births with shoulder dystocia is low. But if it happens to you, it happens to you.
Exactly. Well, and interestingly enough, that mom, I think that was probably her 3rd baby. She chose to have an unassisted birth with her next baby.
Oh,
and
that's interesting.
She called me after the baby was born. She was one of them. And she called me, and she sent me pictures, and we did FaceTime. And I was like, you need to take that baby in. Like, this baby has some serious problems, because she said it was a very extended shoulder dystocia once again.
So she did that and
She
had it in
did.
there, but she would get the baby out.
Yeah.
Yeah, and from when my experience with my first shoulder dystocia, I didn't know what was going on. I didn't, like I said before, Heather explained to me afterward. I didn't know what was going on. She told me I have to do this, you have to do that, and did all the things she needed to do to get the baby out. But the whole time I was just like,
probably
clueless.
Thinking, why is she making me do these
I
things?
didn't know, and that's the thing. Even having experienced it, then the next baby was also stuck, and I remember looking at Heather and saying, "Is the baby stuck?" And she said, "Oh, maybe a little bit." I was like, "Oh, okay." That time I was able to get the baby unstuck on my own because I knew, like, I was like, just let me try.
Right.
And I was able to. But like, when you don't have experience with this and you've never done it, and before I would have, with that, the first sort of shoulder dystocia, before I ever realized there was an issue, I would have gone through multiple contractions of trying to push out. She recognized it didn't come out, the head came out, the rest of the baby didn't come out of the next contraction. She immediately knew what was going on and all the things to do. So again, maybe I just don't have a lot of confidence, but maybe I think maybe you shouldn't have too much confidence in yourself either.
Well, and one of the reasons shoulder dystocias in particular are so scary in the hospital is majority of women have an epidural, or the doctors have only delivered women on their back or slightly inclined, slightly sitting up. Where so it's up to the doctor to try to manipulate and move baby out. When we have a shoulder dystocia, we do different positions because our moms don't have epidurals. So you can do hands and knees. It's called the Gaskin maneuver. You can do runner's lunge. There are all these positions that we can move mom in to help the baby dislodge from the pelvis that they don't do in the hospital. And so it's a little less scary for us than it is in the hospital, but you have to know those positions.
I was very glad that I was in with you with midwife instead of in the hospital when I learned how they do handle that in the hospital.
Right.
But I was also glad I wasn't by myself. So
exactly. There's that.
Okay, another common issue that you might face, it's pretty common, it's cord prolapse. Can you explain what that is and why it's dangerous?
Yeah, so cord prolapse is when the bag of water breaks and at some point the cord comes down in front or out of the vagina before the baby does. So whether the baby's breech, whether the baby's head down, the cord comes out first. And then what happens is the presenting part, typically the head, will kind of put pressure, or I don't want to say crush, but kinks the umbilical cord. And that's how baby gets their oxygen and their blood flow and everything. And so with that compression on it from the head coming against it with the pelvis, it stops that. And that typically is a C-section. So I've had a couple of cord prolapses that we were able to resolve, and mom had her baby very, very quickly after that. We're talking usually within minutes, which was faster than a C-section.
Right.
But that you have to know what to do for those. And you still have to get the baby out very fast from it. So that is something that can happen. It typically happens more often in babies with birth defects or breech babies because the head is typically so round in your average baby that it just kind of plugs the hole, So that one I'm not worried about as much. And then the next one is resuscitation. Babies, it can take a minute for them to breathe, but you have to see the warning signs because there's something, and this is where neonatal resuscitation teaches. I'll just give you the very, very basic, is there's something called primary apnea and secondary apnea. Primary apnea is the baby that you can stimulate and you can rub and you can do things to get baby breathing. And secondary apnea is a baby that you can stimulate till the cows come home, and that baby's not, unless you do the proper interventions, that baby will not survive. And primary apnea, if you aren't looking at the signs and know what to do, can turn into secondary apnea. But the more serious ones are the babies that are born with secondary apnea. Almost every baby is born with primary apnea. You just stimulate the baby, you give them a little massage and they come around, and every once in a while a baby comes out and they're just screaming from the moment their lips hit the air, but it is important to know those things and recognizing them, because you think, oh, my baby's eyes are open. And I'm thinking, if you don't get this baby breathing in the next 60 seconds, they're going to go into secondary apnea. And unless you know NRP, you're a goner.
And do it properly. And
exactly. You don't want to blow out the lungs.
Yeah.
You don't, I mean, there's so many things. And it's seeing the writing on the wall. And that is the big one.
So again, 8 babies, only 1 ever had to be resuscitated. But before he was out, Heather already knew we need to get this baby out fast because she was monitoring. And so that was a birth I didn't get to push nice and wait for my body and not show no way. She was like, you push right now without a contraction, keep pushing and don't stop. And so again, if I had been doing a free birth, I wouldn't have been aware of those signs before the baby was even born. So that would have led to a bigger issue when he was born, and then he had to be resuscitated, which once again, I can't tell you how grateful I am that I didn't have to deal with the resuscitation or my husband or anyone else who might have been there with me.
Yeah. And it is important to see those signs. Many times if I've had a transport to the hospital, or I hear these stories where they say, oh, you're lucky you came in, the nurses will say this, or the doctor will say this to the mom transferring from a home birth or a birth center. Oh, you're lucky you came in, blah, 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 blah. And I'm like, luck had nothing to do about it. We didn't just go, I think we want to go to the hospital. You want to go to the hospital? Let's go to the hospital. We said, we see a pattern happening. We see something happening where we need to be at a higher level of care because that writing is on the wall.
Right.
And
your expertise and your experience and your training is what allows that to happen.
And so if you don't have that level of training, then you won't see the writing on the wall, or you won't understand it. You'll see it, but you don't understand what it's saying to you. And that's where disaster can happen that way.
Yeah.
And that's why you'll get a newer midwife that transports a lot more than a midwife who's done a few hundred births. It's learning how to interpret that writing on the wall and what it shows. And that's what you have to, that's why you're hiring somebody to see the writing on the wall and being able to step in and intervene as needed, or to get you to somebody who can do what is needed. So another complication that can happen is a retained placenta. You usually have about an hour to be able to get the placenta out after the baby is born. Some hospitals say 30 minutes, but an hour is pretty common. And it can take a while for that placenta to come, as long as there isn't excessive bleeding, you're not having any concerns that way. And what makes it really dangerous, though, is the placenta that partially comes off the uterine wall, because then you're going to get a very massive, very quick hemorrhage that can happen. And the uterus isn't clamping down, or can't clamp down, because the placenta is still partially attached to the wall. And that's like one of the phone calls that I got. They were like, with the paramedic dad, it was, the placenta isn't coming, but there's way more blood than we want to see. And so I had to instruct her how to get the placenta out, and then how to stop the bleeding from it. Because an exhausted, tired uterus, let's say a mom who has a 24-hour or 36-hour labor, that uterus just says, I've done my job. I am done. And I am not going to give you another contraction.
Yeah.
And that is not acceptable.
Right.
We need that uterus to contract. And so knowing how to handle those situations and having the supplies on hand to handle those situations is really big.
Right. And so those are some of the most common complications you see. I just want to add that there's always the potential of something that's just not expected and that's not common, and that you don't always see.
Right.
You just never know what could happen.
And the last one I wanted to bring up, because I've seen this a lot online lately.
Okay.
A lot of women's stories is the labor that goes on for days and days and days. Because every time a woman has a contraction, every time that uterus contracts, baby, it's like holding their breath. And you can hold your breath for a while, but after a while, you're like, I'm done holding my breath. I'm getting out of the pool. We're not doing this anymore, right? But imagine having to hold your breath for a minute every 5 minutes for days. You would start to lose your oxygen saturation levels, which is what happens to baby. Mom is exhausted. She's probably not eating much, because once you get into the throes of labor, you and I both know you don't want to eat. You're like, I'll just
Right.
throw it up. I don't want to
Yeah.
eat.
And you keep hoping you're almost done.
Right. And so your energy levels going down, your blood sugar levels going down. If yours are going down, that means babies are going down. And
Mhm.
so these long, long, long births are where you get a baby that is compromised because baby
Mhm.
says, listen, I had reserves at the beginning. I have no reserves now. I'm done.
Uh-huh.
And there's been a lot of women lately that have had incredibly long labors, and the online communities have been like, you can do it, you can do it, and that's great. They're encouraging them. You need encouragement as a
Right.
mom, but you need to see that writing on the wall and say something is happening. And the longer this goes, the more compromised the baby goes, and then you have a baby that dies at birth.
Okay, so
Yeah.
in the next video, we are going to talk about some common things that we've seen in the free birth community, like that, for example, where women are being encouraged by non-professionals, just by other women who are like, well, I've given birth before, I'll give you my tips and encouragement or whatever, and who don't see the warning signs.
Right.
And because the mom is getting this encouragement, they're
And
not.
she's going against her instincts.
Yeah.
This
Mm-hmm.
is something I
Where
tell
they're
moms.
concerned and worried, but the community
Yes.
is being like, don't worry, it's okay, you keep going, you can do
Right.
it.
And
Yeah.
that is something that I am a huge advocate of. You must follow your instincts. This child is yours. You are the guardian of this child. And I believe you have the intuition for this child that someone else doesn't have, because
Mm-hmm.
they're not they're not the guardian. By guardian, I mean the person who is to raise this child and help them in that bond, that intuition,
Yeah.
right?
You gave
And
them life.
exactly. And there's a word I'm thinking of, but I can't think of it. So if you think of the word,
Okay.
but stewardship. You
Okay.
have stewardship of that child,
Mm-hmm.
and that spiritual connection. And if you ignore that, that's when bad things happen.
Mm-hmm.
Never ever ignore your instincts. And the communities, though they're trying to be helpful and encouraging, they don't have the stewardship over that child. They don't have that same instinct. And so they are talking to the mom and basically telling her to ignore her instinct. Mm-hmm. And you can't.
And they also don't have the expertise,
right,
either. So it's a double whammy there.
Exactly.
They don't necessarily really know what they're talking about.
Yeah.
So
exactly.
We will dive deeper into that into the next video. And we just want to kind of close with a reminder, you don't necessarily have to choose free birth or hospital birth. We mentioned that in the previous video, but if you're afraid of a hospital birth, you've had trauma, or for whatever reason you are just set on not having a hospital birth, or potentially really live far out there and it's not a good option for you, free birth does not have to be your choice in order to avoid all of those issues that we absolutely recognize can exist and happen in a hospital. So please watch the next video. You're going to want to watch this again if you are considering a free birth or just interested in learning all about the truth and realities of free birth today.